Hi, this is Dr. Yana Venikova. We're going to talk today about the most common causes of hyponatremia. We're going to talk about hypotonic hyponatremia. Well, hyponatremia means more water than salt in our blood. Our kidneys balance out the water we drink and the solid we eat by diluting or concentrating our urine. This way, serum sodium is maintained in the normal range. But this process is not foolproof. For instance, drinking gallons of water can overcome the ability of our kidneys to dilute urine and lead to hyponatremia. Symptoms of hyponatremia would be headaches, nausea, vomiting, falls, or confusion and seizures. We are going to talk about several types of hyponatremic conditions. We're going to start with those with dilute urine, such as water intoxication, which happens purely from excessive water intake, like in water drinking contests or in psychogenic polydipsia. How do we recognize water intoxication? Our urine is going to be maximally dilute, 50 to 100 milliosmoles per liter, and urine sodium is going to be low from all the dilution. It's going to be usually less than 20. Similar situation happens when patients drink a lot of fluids and have low solute intake at the same time. In these cases, diet does not provide enough solute to excrete all the water. Some examples are beer potomania, when people drink large quantities of beer and eat very little, beer not giving any solute, or tea and toast diet that happens in elderly. So how does low solute intake cause hyponatremia? Normal diet contains 500 to 1,000 milliosmoles per 24 hours. Low solute diet will have less. For example, 200 milliosmoles per 24 hours. So let's assume that your maximally dilute urine is 100 milliosmoles per liter. How much water can you drink on low solute diet? So low solute 200, maximally dilute urine 100. 200 divided by 100 is 2 liters. So if you drink more, you will retain water and become hyponatremic. How do we recognize hyponatremia from poor solute intake? The urine is going to be maximally dilute, and urine sodium, again, is going to be low. Now, let's bring in ADH. ADH helps us maintain plasma osmolality by concentrating urine to retain water. ADH is essential when we are volume depleted or dehydrated. So when urine arrives to collecting duct, it is maximally dilute, 50 to 100. It is then concentrated in the collecting duct as long as we have ADH and as long as we have good medullary gradient. So let's talk about hyponatremic conditions associated with concentrated urine, when clearly ADH is the culprit. So there are several types. We are going to start with appropriately high ADH states. So ADH is a hypovolemic hormone, so it gets released in cases of hypotension. It also gets released when we have effective circulating volume depletion, like in congestive heart failure, or in liver cirrhosis when we have extensive vasodilation. So all those cases can have hyponatremia, and we're going to recognize it by seeing urine which is more than maximally dilute. So urine osmolality that is not maximally dilute. So it doesn't have to be higher than serum. We are not necessarily looking for urine osmolality more than 300. Anything that's not maximally dilute indicates the presence of ADH. So 200 would be high in setting of hyponatremia and indicates the work of ADH. Urine sodium in these cases of appropriate ADH release is going to be low because it's reabsorbed along the nephron due to volume depletion, and it's the work of parallelly increased renin-angiotensin-aldosterone system. So let's talk about some states where we have both high ADH release and high water intake. Some examples are exercise-associated hyponatremia. Certain people will, exercise will stimulate the ADH release, and there's a lot of hypotonic fluids available during marathons, for instance. So some people will develop severe hyponatremia in this setting. Another example is ecstasy-associated hyponatremia. Again, stimulation of thirst, stimulation of ADH, and high availability of water. Now, we always need to remember some endocrine causes of hyponatremia, such as hypothyroidism or adrenal insufficiency. We don't 100% know how these conditions cause hyponatremia, but you can bet that ADH is somehow involved. Now let's move to inappropriately high ADH states. So that's our SIADH. It can be caused by brain trauma or brain tumors or brain hemorrhage. It can be caused by lung disease, including lung cancer, pneumonia, COPD, and multiple medications. How do we recognize hyponatremia from excessive ADH? We are going to see urine that is not maximally dilute, and we are going to have high urinary sodium, usually more than 40. Now there's another miscellaneous cause that I would like to mention. It's reset osmostat, and it happens in pregnancy when normal sodium is a few points lower than in non-pregnant people. So normal osmolality just goes down as if the osmostat is reset. Some words of wisdom. Most cases you will see on the wards are going to be multifactorial. See if you can find all the predisposing factors. Good luck.